male patient in 30s presented with history of blunt trauma in past and history of vision loss. He was noted to have large lenticular coloboma. Intraoperatively, rhexis was done, keeping the rhexis edge away from the coloboma area. Capsular staining was avoided for fear of loss of contrast if the dye went into vitreous cavity. Gentle hydrodissection and hydrodelineation was done so as to make the nucleus free from all the attachments, and free nuclear rotation was achieved. The nucleus was found to be quite hard, and chalk technique was used to manage the nucleus. Each piece was removed from the capsular bag before emulsifying and removing. Since the rest of the zonules except for the colobomatous area were quite sufficient, it was not necessary to support the colobomatous area with capsular hooks. Hydroblast procedure was done to loosen the cortex, and cortical removal was done using bimanual technique. While doing bimanual technique for cortical removal in area of coloboma, it was kept in mind not to engage the capsular bag, and the cortical material was aspirated, brought into the center and then removed, rather than causing traction on the zonules. Once the cortical removal was done, an endocapsular ring was inserted into the bag. The care was taken to insert the endocapsular ring from opposite paracentesis so that the closed end of the endocapsular ring would cover the colobomatous area. The trailing end of the endocapsular ring got slipped into the anterior chamber, and it was manipulated into the bag using two Sinskey hooks. Then the hydrophilic IOL was inserted into bag, and haptics were oriented along the axis of the coloboma. Once IOL was placed, the rhexis was enlarged so as to avoid capsular phimosis in future. The viscoelastic was removed and side ports were hydrated. Important point in this case is to avoid any zonular stress intraoperatively. It may not be necessary all the time to use the capsular hooks or CTS. Thank you for your kind attention.